Good evening. My name is Filipe Lopes. I am a urology resident at Hospital Santa Maria in Lisbon, Portugal, and I would like to thank the organization of this ICS meeting for giving me the opportunity of presenting this study that explored the technique of the transurethral resection of the prostate, namely the impact of the resection weight on the surgical outcomes. I have no conflicts of interest to disclose. So we know that even though TURP is a decade-long surgery, the necessity of a complete adenoma resection is still controversial, with several studies in the literature with complete opposite conclusions. With such different results, we thought possible that some patients may benefit from a complete adenoma resection, while others may do well with less profound resections. Interestingly, a team led by Dr. Hackenberg tried to correlate TURP outcomes not with the weight of resected prostate, but with the pre-operative prostatic volume and the residual prostatic weight, with negative results. We theorized that patients with more severe bladder outlet obstruction may benefit more from a higher weight of resection, while patients with only mild bladder outlet obstruction may do well with incomplete adenoma resections. In sum, the questions that we tried to answer were: may bladder outlet obstruction severity affect a possible influence of prostate resected weight in TURP outcomes? Could patients with only mild bladder outlet obstruction be better candidates for less extensive TURPs, such as exaculation preserving techniques? In order to answer these questions, we did a retrospective analysis of clinical data of patients submitted to TURP in our center between 2012 and 2015. Exclusion criteria were previous LUTS surgery, prostate cancer, urethral stricture, or voided volumes in uroflowmetry under the 125 milliliters. We then stratified our population according to pre-operative maximum urinary flow on uroflowmetry. The cutoff value was 10 milliliters per second, and this cutoff value was defined according to the Sirocchi nomogram, since this nomogram predicts that a Qmax under 10 milliliters per second is a very strong predictor of bladder outlet obstruction in men. Here we present the characterization of our population. We studied a total of 185 men with a mean age of 58.5 years. The average prostatic volume was 51.78 and the average preoperative urinary maximum flow was 8.78. Postoperatively, the average urinary maximum flow was 14.8. When analyzing the population as a whole with no stratification, we found no statistically significant correlation between prostate resection weight and post-operative Qmax or Qmax change. Here, neither absolute resected weight nor the ratio of resected weight per total prostate volume showed statistically significant associations with TURP outcomes. Similarly, in the group of patients with preoperative Qmax over 10 milliliters per second, no correlations between the same variables were found, suggesting that in patients with only mild obstruction, the weight of resection has no impact on the outcomes. However, when analyzing only the group of patients with a preoperative Qmax under 10 milliliters per second, we found that the resected prostate weight, both the absolute value and the percentage of resected weight, had a statistically significant correlation with post-operative Qmax and a Qmax perioperative change. Also of notice is that the two analyzed groups had no statistically significant differences in clinical characteristics other than, obviously, Qmax, meaning that the differences found between the groups are not due to some other confounders than preoperative Qmax. This study has important limitations. We used uroflowmetry parameters to predict bladder outlet obstruction. But obviously, bladder outlet obstruction is a urodynamic diagnosis, and so urodynamic studies would be very useful to better stratify our population. Unfortunately, we do not routinely perform urodynamic studies to all patients before TURP, and therefore the exclusive selection of patients who had a urodynamic study would be a very important bias. Also, since the main objective of TURP is the relief of lower urinary tract symptoms, patient-reported outcome tools such as IPSS would be clearly beneficial. Qmax is, however, strongly correlated with IPSS, as some studies have already reported, and so we feel that Qmax is a fair TURP outcomes assessment tool. In conclusion, our study suggests that patients with lower preoperative Qmax probably benefit from a complete adenoma resection, while in patients with preoperative Qmax over 10 ml per second, a less profound prostate resection may be considered. Thank you very much for your attention.